Hello, today's topic for discussion would be leukemia. And as we all know, leukemia is one of the most frequently encountered hematological diseases where we see abnormal increase in immature WBC count. Okay, and about every year, about 3 lakh new cases globally are detected. Leukemia is detected in about 3 lakh new cases, and the survival rate is usually less than 5 years. After treatment for leukemia cases. So today we'll be dealing about the various variants of leukemia, the clinical features, the dental considerations, and about the management. As we all know, leukemia is a condition where it is characterized by proliferation of WBC cells of their precursors that occurs in an uncoordinated fashion. That is, it is in an abnormal proliferation where usually we see a immature circulating WBC cells. The proliferation is also very uncoordinated and it occurs in independent fashion, and these are considered to be a true neoplasms, usually a malignancy of WBCs. And these malignant cells, usually what happens is because of increase in the count of WBC cells, they actually what they do, because of this increase in WBC, they replace other lineage of cells such as red blood cells and also your megakaryocytes, that is your platelets, by suppressing the other marrow elements, because as they are increased in number, what happens, they infiltrate into the bone marrow spaces, leading to decrease in production and also in the maturation of other types of cells, like those are leading to thrombocytopenia and anemia also. And other important thing, if you have observed that we are talking that these WBCs which are being proliferated are immature. That means they does not have or they lack the proper functioning of these actual leukocytes. Okay, so these are not normally functioning leukocytes. Though they are increased in number, the function is not proper because of their immaturity. They have not matured. In this picture, we can see how a normal blood and a leukemic blood is looking. In the normal blood, we have all the proportions, maintained. The platelets proportion, the WBC count, and the RBC count is maintained in the normal limits. Whereas in leukemia, what happens, because of the increased WBC count and the decrease, it is been suppressing or it is crowding out. The crowding out of RBCs and the other megakaryocytes can be seen in case of this leukemia. Coming to the etiology, before coming to etiology, this leukemia could be of involving various cells of different lineages. For example, lymphoid lineage, and you have a myeloid series. In the lymphoid lineage, usually the lymphocytes and lymphoblasts have been affected. In the myeloid series, we see the erythrocytes, the granulocytes are being affected, and also the monocytes and platelets are affected in case of this myeloid series. Now coming back to our etiology of this leukemia is usually genetical, most predominantly genetical and familial in origin, and we have some syndromes that are usually associated with this leukemia, and those syndromes include Bloom's syndrome, we have Down syndrome, we have familial monosomy 7 and Fanconi's anemia. Also, viral etiology has also been known to be associated with it, and these viruses most commonly include our HTLV, that is human T lymphocytic virus 1, HSV, and also this Epstein-Barr virus are usually been associated with leukemia. And other conditions such as ionizing radiation and certain agents like aniline dyes and benzol, these also are known to cause a leukemia. Now coming back to the classification, based upon the cell that is been involved, based upon the lineage that is been involved, they are again divided into myeloid series and lymphoid series, also monocytic leukemia. Based on this myeloid series, it is called as myeloid leukemia. Here, granulocyte series are being usually involved. In case of your lymphoid leukemia, lymphocytic series is involved. That is, lymphoblasts and lymphocytes have been involved. And in case of monocytic leukemia, it involves a monocyte series. However, this monocytic leukemia usually comes under your myeloid series. Okay, because it is another branch of myeloid series. Usually, it comes under the myeloid leukemia. Again, based upon the duration. The duration of occurrence, it is again divided into acute, subacute, and chronic. In acute leukemia, what actually happens is it usually occurs within short duration of time, within lesser period of time, and this acute leukemia usually bursts out within 3 months period of time, and it is very rapid in occurrence. And in acute leukemia, what happens is usually there is increased proliferation of WBC cells, there is excessive production of WBC, and this excessively produced malignant cells, what happens is immature WBC or the malignant WBC, they are spilled into the peripheral blood in case of your acute leukemia. In case of chronic leukemia, it usually is progressive in nature. It may take up to 6 months to 3 years, to give up the symptoms what, this chronic leukemia usually consists of. And this chronic leukemia, what happens is, it usually, the symptoms of chronic leukemia are usually manifested after, there is huge number of WBC that has been produced, but these WBC get accumulated. They accumulated, into the various organs, like in the bone marrow, in the cells, bone marrow, in the tissues like gingiva, in other, visceral organs. This excessively produced WBC are being deposited, or they have been infiltrated. Once they are infiltrated, what happens is the symptoms starts producing. Like if they are infiltrated in the bone marrow, they crowd out the normal, RBCs and the normal megakaryocytes, and the symptoms of them gets, exposed. And then if it is infiltrating the spleen, then we see abnormally enlarged spleen in case of chronic leukemias, and the symptoms of the splenomegaly also comes out. Only then, actually, only after those symptoms which have been seen, this chronic leukemia is usually diagnosed usually. So based upon the duration and based upon the how this WBC, excessive WBC that is produced is presenting the symptoms also, it is again divided into acute, subacute and chronic types. So based upon this duration and based upon the series that is being involved, it is again divided grossly into 4 main types. These 4 main types includes acute myeloid leukemia, acute lymphoblastic leukemia, chronic myeloproliferative leukemia and chronic lymphocytic leukemia. So these are the 4 main types of leukemia that is usually involved. Now coming back to the clinical features. In the clinical features, usually when we're talking about acute and chronic type, in the acute one, usually younger children are more commonly involved, males are most commonly involved. In this case, what happens in acute is, because it is very rapid in attack, it occurs in a shorter duration period, but it is usually very fatal. When it comes to chronic leukemia, what happens is, it is a slower insidious in origin, it is progressive in nature, it shows a slow course. If it is treated properly, the survival rate is usually better when compared to the acute leukemic cases. And though this, most of the clinical features are usually because of this immature WBC, though the WBC number is high, they are non-function, that's the first one. Second thing, they crowd out the normal cells. So based on that also, various clinical features are being seen. Coming back to these clinical features, because of though there is an increased WBC, because of the decrease in the function, what happens is, patient usually presents with night sweats, there will be frequent infections, there will be long-term low-grade fever usually encountered. Due to decreased RBC, we see anemia, pale skin, and because of anemia, what happens? The oxygen carrying capacity of the blood is decreased, and patient usually exhibits shortness of breathing on exertion. Okay, patient usually will have palpitations, shortness of breathing, etc. Due to decreased megakaryocytes, that is decreased platelets, what happened? There will be all bleeding diastasis occurs. That is like petechia, patient will have excessive bleeding, hematomas can be seen in these cases. Affect and viscera, that is the other body organs also, what happens is, this immature WBC start infiltrating into the visceral organs. Because of this, what happens? There will be enlarged lymph nodes. If they are infiltrated into the joint and also into the bone, especially in the bone marrow, there will be bone pain and joint pain. Hepatomegaly and splenomegaly, because of infiltration of these WBCs into liver and spleen respectively. In the skin, they get infiltrated, in the CNS, they get infiltrated, in the meninges, and also other organs are also being involved in case of this leukemia. So grossly, the common symptoms are, patient exhibits weight loss, patient exhibits fever, frequent infections because of decreased WBC count, easy shortness of breath, weakness, muscular weakness can be, patients could present with muscular weakness, pain in the joint, tenderness of the bone and tenderness of the joints are usually encountered. Psychological fatigue will be present. Patient usually will have loss of appetite, patient will have fatigue, lymph node will be enlarged because of infiltration, night sweat, easy bleeding, bruising, purplish patches or spots can also be seen. Now coming to acute leukemia, as I already told, this acute leukemia is nothing but it could be either of myeloid or of lymphoid series, precursors clonal proliferation. It is a clonal proliferation of your myeloid or lymphoid precursors with reduced capacity to differentiate into more mature cellular elements. In short, it is nothing but the myeloid or lymphoid precursors are present in an immature form in the circulating blood. Okay, and this acute myeloid, coming back to our acute myeloid leukemia, usually children are most commonly involved and young adults, and children in acute myeloid leukemia, what happens is children of less than 2 to 5 year age group can also be included and more commonly seen in males. In this, what happens is there is increased production of immature leukocytes, which are nothing but your myeloblast. Okay, in acute myeloid leukemia we see increased number of myeloblast, and these myeloblasts, what they do is they rapidly fill the bone marrow. Okay, the bone marrow is being rapidly filled out and they crowd out your other normal cells like in any other form of leukemia. Because of this, what happened? There will be increased infections. Because of increased infection, it will be fevers, fits. Because of infiltration into the bone, they will have bone pain, and organomegaly, that is splenomegaly or hepatomegaly can be seen. Because of the infiltration into the lymph nodes, into the salivary glands, there will be adenopathy. And when they are infiltrating into the salivary glands, what happens is there will be decreased salivation in these cases. And meningeal involvement can also be seen, but it is not very commonly seen. It is one of the rare manifestation. Skin infiltration is usually seen in about 10% of people. What happens is these immature leukocytes get infiltrated into the skin and they form small nodule-like structures. When these nodules, when we excise them and we cut them, when we on cross sectioning, when we see a nicely greenish colored color can be seen on the freshly cut or freshly incised nodules on the skin. And this is nothing but chloromas. They are called chloromas because of the color they produce. These are nothing but tumors in the skin, bones, and they have more leukemic chloromas are more commonly seen in the eyebrows. Okay, so this is one of the most common site or most common location. And then in this, what happens is in case of acute myeloid leukemia, about 30% of cases usually will have blast cells. That's why myeloblast, and neutropenia is one of the most common feature. Apart from this, what happens is there will be other cellular manifestations also, like because of decreased RBC there can be anemia, and it's clinical features like pallor, lethargy, dyspnea and fatigue can also be seen. And in thrombocytopenia can also be seen. Infections are quite common in this because of non-functional WBC. And coming to histopathology, when we actually see the slide of the peripheral blood smear of these cases, we see a bizarre shape, abnormal granulation and inability of platelets to aggregate and adhere. So in the smear what we see, this is the features that we see. And in investigations when we do, we see normochromic anemia, normal or raised WBC can be seen. Definitely hyperleukocytis, about 1 lakh per microliter can be seen. Predominantly myeloblast and promyelocytes can be seen in these cases. Thrombocytopenia and neutropenia in other conditions. Next we have impaired granulocyte function, neutrophil lobulation, phagocytosis and migration is also impaired in these cases. Now coming back to acute lymphoblastic leukemia. Acute lymphoblastic leukemia is usually more commonly seen in childhood. In about 3 to 6 years age group it is commonly seen. However, it can also occur from age group of 1 to 2 years. And in acute lymphoblastic leukemia, other common clinical features include bleeding because of thrombocytopenia, infections because of neutropenia and fever is seen. Fatigue and intolerance is because of anemia can be seen. In bone pain also, one of the most common feature of acute lymphoblastic leukemia, this bone pain is because of because of the infiltration. It leads to infarcts and subperiosteal infiltrates. These leukemic cells will be invading into the bone marrow, leading to this condition. And acute bone pain is one of the most common feature of acute lymphoblastic leukemia. And patients also exhibit lymphadenopathy, splenomegaly, hepatomegaly, and CNS manifestations can also be seen in these cases like headache, diplopia, vomiting. This is because of the meningeal spread. Because of meningeal spread, we see conditions like headache, diplopia, and vomiting. Now coming back to our chronic leukemia. As I told, chronic leukemia is because of accumulation. Remember, it is because apart from proliferation, it is accumulation of mature myeloid cells and their progenitors. Most commonly, CML, about 90% of cases involves this Philadelphia chromosome, and this CML accounts for about 15 to 20% of all leukemias. CML is most commonly seen in middle age group, that is in about 65 years of age group, most commonly seen in males, and less commonly or rarely seen in children. And it actually occurs in about 2 different phases, that is chronic phase and also an acute phase. And this condition, that is CML, is usually a progressive condition. It is very slow in progression and it is usually undetected. As I have earlier as I have told, it can occur from 6 months period of time till 3 years period of time. Okay, it can go undetected if the patient's symptoms are not properly detected. Usually it if these leukemic cells get proliferated, they get infiltrated into other viscera. Splenomegaly could be the symptoms of splenomegaly could be the very first sign in case of this CML. By the time patient usually comes to us with the CML, most of the organs get infiltrated with this or accumulated with this kind of WBCs, immature WBCs, and there can be enlargement of salivary glands, enlargement of lymph nodes. Because of this enlargement of salivary glands, again there will be decreased salivation. Okay, and we see leukemids. Leukemids are nothing but these are papules, pustules or bullae or areas of pigmentation. We see herpes zoster and we also see itching and burning signs. Okay, this is all because of neutropenia again, that is decreased ability to fight against infection. These leukemids are usually seen in case of your CML. And other symptoms of a decreased erythrocyte production or decreased megakaryocytes, we see the symptoms that have been associated with it. Because of decreased platelet functioning, we see petechia, we see ecchymosis, etc. We see nodular skin lesions and bone lesions. Because of this bone lesion, what happens are usually osteolytic in case of CML, and because of this osteolytic lesions or osteomyelitic kind of lesions, what happens is it can lead to pathological fractures. Another again most commonly encountered one in case of CML. And increased myelopoiesis is usually restricted predominantly to granulocytes, monocytes and macrophages. There can be increased erythrocyte production, which is again one of the rare feature, not very commonly seen. And we have something called as blast crisis in case of CML. In this blast crisis, what happens is, as this disease CML is being progressing for a longer period of time, it progresses to such an extension where there will be it starts functioning, it reaches some endpoint and it starts functioning again like an AML. So this feature is called as blast crisis. Usually in case of this attaining to blast crisis, what happens, it usually passes through a phase which is an aggressive blast phase. And gingival hyperplasia and edematous kind of gingiva is most commonly seen in case of your CML again. Now, coming back to investigations, usually leukocytosis with immature myeloid cells and blast cells are present, usually in less than 5% of cases, and circulating neutrophils and myelocytes can also be seen. In about 10% of cases, we see increased basophils, and eosinophils are also usually more predominantly seen. And in case of chronic leukemia, as I told you, WBCs are usually about greater than 1 lakh in number, and we see basophilia, which is again a characteristic feature of CML. Coming to bone picture, usually we see hypercellularity in case of this bone picture. We see increased myeloid cells and decreased erythropoietic cells, and megakaryocytes are also very smaller in size. When we do a bone aspiration in case of CML, what happens is, on testing it, we actually see a nice sea blue histiocytes. The sea blue histiocytes are nothing but macrophages with abundant wrinkled greenish blue cytoplasm, which is again a characteristic feature of your CML. It is nothing but cells seen in bone aspirate. We see nicely sea blue histiocytes, which is a characteristic feature of CML. Remember this. And usually Philadelphia chromosome is associated in about greater than 90% of cases in case of CML. Apart from this, we see reduced neutrophil alkaline phosphatase and elevated serum LDH, and also uric acid and vitamin B12 can be associated in case of CML. Now coming back to chronic lymphocytic leukemia. In chronic lymphocytic leukemia, it is also called as small lymphocytic lymphoma, usually seen in case of older adults and also in middle-aged people. It is again characterized by proliferation and accumulation of morphologically altered, morphologically they appear mature, but biologically these are immature B lymphocytes. That is nothing but in chronic lymphocytic leukemia, we have more number of immature B lymphocytes. Because of its increased B lymphocytes and being immature, the actual function of these B lymphocytes is not proper in these cases. Early features would be lymphadenopathy and splenomegaly. Patients usually have fatigue, weakness, dyspnea because of anemia. Infections and enlarged lymph nodes are commonly encountered. Enlargement of salivary glands and tonsils. This is because of infiltration. Remember, because of infiltration, what happens? There will be decreased salivation. And we have occasional features like GIT symptoms, skin infiltration, CNS manifestations. We also see vision disturbances. Richter's transformation is one of the common features in case of this AML. Now we have certain reaction called as leukemoid reaction. The difference between this leukemia and leukemoid reaction is the WBC number in case of leukemia is usually greater than 50,000. Usually it can reach up to 1 lakh, whereas in case of leukemoid reaction it is less than 50,000. The leukocyte alkaline phosphatase, it is decreased in case of CML, variable in other leukemias, whereas in leukemoid reaction we see markedly increased leukocyte alkaline phosphatase. And platelets, usually they can be in leukemia, they can be either very high or very less. We see giant platelets. In case of leukemoid reaction, usually we do not see much increase in case of your megakaryocytes, that is in case of platelets. Usually they are normal in function and normal in morphology. Whereas in case of leukemia, what happens is they are not functional, they are usually dysfunctional. That is, the function is altered in case of platelets, is altered in case of leukemia. And RBC morphology in leukemia is again frequently abnormal because of crowding out of this RBCs because of increased WBC. Whereas in case of leukemoid leukemia, what happens is leukemoid reaction, they are usually normal. RBC is usually normal, and the clonality, leukemia is monoclonal, whereas a leukemoid reaction is usually polyclonal. And coming to management of leukemia predominantly is through chemotherapy, and we have various regimens for that. In case of chemotherapy for acute lymphocytic leukemia, prednisolone, vincristine, asparagine, daunorubicin could be used. In case of AML, we go with anthracycline, we go with cytarabine, monoclonal antibodies. CLL, we have regimens like CHOP, CAP and CVP. Chlorambucil, furan analogs and interferon could be used. In case of CML, imatinib, mesylite, hydroxycarbamide can be used. Apart from this chemotherapy, we have various therapies like stem cell transplantation can be done, and then we have radiotherapy. In some cases, radiotherapy could be helpful, especially for palliation. And we have something called as leukophoresis. Leukophoresis is a process where we actually separate this excess, it's up in the collected blood, it separates and collects the specific WBC, and then it separates it from or filters it from the blood. That means large amount of WBC are being separated from the blood, and this blood is again repumped into the human body through a specific machine. In this leukophoresis, what happens is, by doing this process, we are removing the abnormally proliferated or abnormally produced WBCs from the circulating blood, and this can, patient can survive with this for about 2 to 3 months period of time, and usually this is more helpful in case of patients of less than 60 years of age group. With this, what happens is the 5-year survival rate has been increased in more than 60% of patients. And then newer therapies like biologic therapy or targeted therapy is present, where we can use imatinib or we can use interferon alpha, etc. for these cases. Now coming back to oral manifestations, usually oral manifestation could be gingival manifestations are more commonly seen in case of leukemia. Boggy kind of gingiva, enlarged friable gingival hyperplasia is usually seen, and gingiva is so friable, easy hemorrhage can be seen, petechia and ulcerations of mucosa. Petechia is because of thrombocytopenia again, and this gingival hyperplasia is because of leukemic infiltrations into the gingiva. We see discrete punched out lesions because of neutropenia. Oral candidiasis is also one of the commonest features. This is also again because of neutropenia. Coming to hard tissue findings, usually the teeth are they are lost very fast because of rapid loosening of teeth. This is because of necrosis of periodontal ligament. Necrosis of periodontal ligament again because of your neutropenia, increased neutropenia. And then there can be destruction of alveolar bone. I already told you this, if the leukemic infiltrate involves the bone, then there could be most commonly an osteolytic lesion leading to pathological bone fractures. Again, pathological fractures of your mandible or the jaws can be usually encountered. So what happens, how do you actually treat, or what are the dental considerations when a patient with leukemia usually comes to us? First of all, when a patient with leukemia comes to us, before doing any treatment, take an informed consent, and also take a consent from the physician before starting any elective dental surgeries. And first of all, preventive and proper oral hygiene maintenance is one of the important things to prevent any other further dental issues being facing up. Avoid aspirin and NSAIDs in these cases because already platelets are compromised and patient is in thrombocytopenia. Whenever you are doing the procedure, strict asepsis is required because already there is neutropenia in these cases. Whenever there is gingival bleeding, you can go for local styptic methods. You can use desmopressin, or if it is very severe, go ahead with platelet transfusion. In these cases, it is usually LA GA is contraindicated, however, and conscious sedation can be used in these cases. Regional LA is also contraindicated in case of severe hemorrhagic tendency. If patient is under very severe hemorrhagic tendency, we avoid this regional LA because there can be, the site of injection there can be a large hematoma. Because patient is having anemia, it is contraindication for GA, and IM injections also, especially in case of deltoid, etc. These IM injections are also usually avoided because of increased tendency to form this hematomas. Usually surgeries are deferred until a remission phase, and surgical procedures are planned. If at all planned, they have to be planned such a way that they are usually less traumatic procedures or atraumatic procedures, and we can go ahead when we are doing any sutures, we can go ahead with polyglycolic acid sutures again. In these cases, as I already told you, there is high risk for infections like herpes zoster and also candidiasis. So antiviral and antifungal prophylaxis can be used, whenever there is necessary. Whenever there is a need for it, you can go ahead with it. And this is about leukemia completely. And we have certain diseases called as myeloproliferative disorders, which are actually characterized by proliferation of bone marrow cells other than the leukocytic stem cells. This include polycythemia rubra vera. We have angiogenic myeloid metaplasia or essential thrombocythemia. Okay, these are other myeloproliferative disorders. This is because of increased proliferation of your bone marrow cells other than the leukocyte stem cells. Just for an idea, I have just added this myeloproliferative disorders. So this is about leukemia. We have seen about various variants of leukemia and the clinical features and how do we actually treat or the management procedures for it. Thank you.